Good afternoon, everyone. My name is Amelia Ling, and I'm a second-year master's student in the Department of Epidemiology, focusing on infectious diseases. I first met Dr. Paul Farmer when he pleasantly surprised my research group and briefly sat in on our meeting discussing a TB diagnostic rollout program. From my account and many others, his exciting nature and deep intellect is captivating, as I'm sure you will all agree today. Dr. Farmer's passion and dedication for his work are world-renowned, best known perhaps through Partners in Health, his many books and publications, and the bestseller, Mountains Beyond Mountains. Dr. Farmer graduated summa cum laude from Duke University with a Bachelor of Arts in Medical Anthropology. He continued his education at Harvard University, where he earned an MD and a Ph.D. in Medical Anthropology. During his time at HMS, Dr. Farmer, with his colleagues, including Jim Kim and Ophelia Dahl, co-founded Partners in Health, focusing on improving healthcare in Haiti. Today, Partners in Health is an international organization working with partners in Liberia, Russia, Haiti, and many other countries. In addition to directing Partners in Health, Dr. Farmer has served as a UN Special Advisor to the Secretary General and writes extensively on social inequality and health. He is Harvard's Colocotronis University Professor, Chair of the Department of Global Health and Social Medicine, and Chief of the Division of Global Health Equity at Brigham and Women's Hospital. Most recently, he returned from Liberia with a group of physicians and health activists in response to the Ebola epidemic, a current example of a medical issue where leadership has been particularly critical. Before I turn the session over to Professor Michelle Williams, who will be moderating today, please join me in welcoming Dr. Paul Farmer to the Voices in Leadership series at the Harvard School of Public Health.
Thank you. Thank you very much.
Thank you, Amelia. And welcome. Welcome to all of you and here in the studio, and to those of you who are listening and viewing this from the overflow room, and even those viewing from more remote sites. Welcome to the Voices in Leadership seminar discussion series. It's a real privilege for me. First of all, I'm Michelle Williams, and I'm chair of the Department of Epidemiology, and it's a real privilege to be the moderator of this session today. I should tell you that the Voices in Leadership seminar series goal is to provide students with an opportunity to really understand and appreciate the knowledge around leadership as it is applied to solving some of the most challenging problems in global public health and the health sciences. And I think today we have with us a paragon of leadership, particularly in solving the most recalcitrant issues in resource-poor settings. Dr. Farmer has done this by combining healthcare delivery with scholarship and research and advocacy in addressing some of the biggest problems in some of the most resource-poor settings. Dr. Farmer, I'd like to start by asking you a little bit to trace the arc of your career, beginning in Jenkins Creek, Florida, to Duke, to Boston, Harvard Medical School, to the development of Partners in Health.
Why shouldn't I go back to herpetology as a 10-year-old? that is going back a ways. Jenkins Creek is in very rural coastal Florida, and a lot. So getting to the leadership question right away, I was lucky. I had a high school guidance counselor, a teacher who took an interest in, maybe more of an interest in, my college career than I did. If someone would have asked me, well, where are you going to go to college? I would have said, well, see, maybe it could be Florida State or University of Florida or University of South Florida. My horizons were rather not that atypical of a public school student at the time, and she said, but when I went from, you asked the question about the 10-year-old obsession. I kind of went up the evolutionary tree. I started with botany and then herpetology. Oh, well, this is a reference that will not be familiar to your viewing audience because they didn't hear the 10-year-old question. Anyway, I got up to the evolutionary tree of wanting to be a physician. Again, I'm glad that no one said to me, well, why do you want to be a physician? How would I have known? I was, 15, 16 years old. But happily, I was steered towards Duke. And I applied, the only place I applied to wasn't organized to get applications in, and then I ended up there. And so my point about how the arc is the take-home message, as they say in medical school, is there's a lot of serendipity involved. It's very hard to plan out. How would you plan out that your high school guidance counselor, who you've actually, pulled pranks on and done immature things to, is going to say, well, maybe you should think about this place? And how would you know that you would meet through scholarship and reading someone who is at the University of Washington but headed to Harvard Medical School? I think you have to be open to serendipity. And that's part of leadership, is not being afraid. Obviously, these are not dangerous things that I'm describing, going to Duke or going to Harvard. There are some dangers, but they're not of the physical sort.
But a willingness to go outside of your comfort zone,
right, and
to
to
go
do something
outside of what's familiar to you.
That's right. Something you've never heard of. Yeah. And that's how Haiti. That's how I ended up in Haiti at 23 years of age, going from some laboratory research, directly to Haiti, and that changed my life.
So tell us a little bit, in concrete terms, what were some of the lessons you learned early on in Haiti, which is so different in so many different ways, even from Jenkins Creek?
It was very different, and one of the things I learned early on, first of all, I'd like to say that, in terms of leadership, there's all of these unglamorous parts of leadership, right? Yeah. Persistence, serendipity, being open to something new, believing that your path may not be laid before you, and then finally learning how to play nice with others. I came from a big family of 8 people, let me tell you, and as the herpetologist in the group, now that is on film, let me just say that one of my brothers became a professional wrestler with World Championship Wrestling. I did not pick fights with those guys, my brothers and sisters. Learning how to play nice with others, that's a big part of leadership. And then finally, as you go on, you start saying, hey, wait, leadership, maybe that's about creating a stage on which other people can lead. That's a form of leadership. Building capacity. And those terms, when I went from Haiti to Harvard Medical School, I'd already met the people with whom we would start together, Partners in Health. Our Haitian colleagues, like Fritz Lafontaine, still alive, he's in his 80s. Tom White, who I met when I came up here to interview. Jim Kim, also met when I came here to interview through a professor, Ophelia Dahl, I met in Haiti. And my college roommate, Todd McCormick. Those are the people who started Partners in Health, and that was 30 years ago. Leadership and development. So we didn't. If we had talked about leadership back then, we would sound as pretentious as some of us probably were. But you have to be. There's all these unglamorous, and one of the biggest ones among them is persistence, learning to play nice with that's why we all still work together. It's not like it's been easy. We've gone through some very difficult times together, but we stuck together, and that's a big part of it, is learning how to play nice with others, but also how to keep something going on. So when we talk about sustainability, we can flip that on its head and say, not is this sustainable, but rather how do we sustain it, whatever it is. In public health, that's a huge part of the struggle. And for leadership, is to say we will sustain it, not can we sustain this? And that meek and retiring approach to public health challenges, I don't think it works. Yeah.
In sort of my own understanding and looking at the arc of your work in Haiti in particular, one of the first projects you started with was the Bread Project, which is a nutrition
You did your homework,
project.
Michelle.
Oh, of course. And then you developed that to the 2-room clinic, and that further grew. Can you tell us a little bit about your approach in how you start a project, prove its concept, and then scale? Because in addition to sustainability, scaling something that works to make it more impactful and sustainable is really a challenge for those young leaders out there who want to move from the pilot project phase to actual implementation.
Well, a couple of things that I would say. Again, I think if you were to go into a seminar or a classroom, as I do every week, whether here or in Liberia or Haiti or Rwanda, and you said, well, some of the things you need to think about, and I could make a list of virtues or strategies for bringing something to scale, those would be less interesting, I think, than the stories that don't get told. And in fact, in our first years there, and I say our because remember some of the people we work with died, and I'd like to talk more about that if we have a chance, but those who have not still work together, right? And the way we told the story to ourselves when we were young or younger, we were very young, some of us, was, isn't it great what we're doing here? Isn't it a success? We didn't use the words that baldly, but you know what? It wasn't great and it wasn't a success. It was bad and it was low quality. I was going to say low rent. It was really of poor quality what we were doing. And that was, and by the way, the bread project, it was not a mistake to think that people needed food security. We were right on that at least. But it was a mistake, that project, the way we did it. I mean, in the middle of a rural Haiti where there's a major problem with reforestation, I don't think having a wood-burning oven is a good idea. I didn't have to go to Harvard School of Public Health to figure that out. But, so there's all of this difficult process, and we are kind of coached to tell victory narratives. And I bet I did so in my interviews at Harvard Medical School. I bet I was, and I'd like to blot that out of my memory. It worked out okay, I guess, because I got in, but I'll bet you I told a very, not that I didn't think it was true, but a very positive story of my year in Haiti between college and medical school, but it was not positive. It was full of pain, it was full of mediocrity and worse, and when we started thinking about scale, which actually we learned to think about that here at Harvard School of Public Health, where there had been, because we took the community survey from a project that had been headed by some professors here.
Population Sciences Department.
Exactly. And in the team that we had of the 6 people, Haitians, who I worked with, all my age, I was going between Harvard, Haiti. Half of them were dead before they were 30. 1 in childbirth, 1 from malaria, from cerebral malaria, and 1 from typhoid perforated ileum. How could that be good? I mean, it was painful. And again, then the real virtues, I think, that are related to leadership come through. And that's persistence, critical, self-critical reflection, of course, listening to people, right? I mean, if you want to figure out how to sustain something, get a good analysis of what the problem is, and listen to people. And in my experience, Haiti was the best teacher, in part because my hosts there were only too happy to talk to me about what they thought was wrong with their lives and their world, and they invariably tied it to the rest of the world, right? So it was a global political economy. And I hope that I learned some of that in college, but the Haitians would have it no other way. The idea that there was some nation called Haiti that had boundaries so that a sustainable program would have to fit into whatever their GDP was, they rejected that. And because they said, wait, our people were kidnapped from West Africa, we lost, things. And that's the kind of historical analysis I get all the time from Haitians, and it was a great lesson. I learned a lot from them. Now that's a very long answer to your question, but the first order virtues are usually really not the real lessons. It's the reflection that leads you to think about the tougher lessons.
So I wanted to ask a little bit about further along the lines of reflection. As you grew the Partners in Health concept and operationalized it, in 1993 you took your pivot Up to that point, you were delivering healthcare services. But in 1993, you chose to develop the Institute for Health and Social Justice with the award that you received from the MacArthur Genius Award. And that is an expansion of the scope in a remarkable way, where you have now added this very large additional agenda of research to the Partners in Health mission, which was, you know, quite saturated with providing health delivery in a resource-poor setting, undergoing still local challenges. Can you tell us a little bit about how you made that decision, the strategy, the thoughts that went in, and some of the early implementation of this research arm to a health care delivery program?
Well, I'm so glad you brought that up, because it allows me to say that that was a pivot, but a pivot back towards our mission. Because we had gotten some things right when we were students. Because not all of us were students, but Jim, this is 1987, we were in medical school and graduate school. Ophelia Dahl was probably at Wellesley, a college student. So the original mission of Partners in Health was to serve the poor, and particularly focus on their needs, which again, I've told you, they're only too happy to say in my experience, first in Haiti, then across Latin America and some places in Africa. But second, to link that service to formal training program, what you called just a minute ago, capacity building. And third, to generate new knowledge. So we actually got the mission right. And that's why some of us pursued graduate school, a Ph.D. as well. I'm sure it's why you pursued a Ph.D. And I see that you did not read my 1,000-page doctoral thesis.
No, I did not do that as part of my homework.
Which calls for linking, I'm kidding, it's really, actually any thesis that's 1,000 pages long, you can bet is bad. And after I graduated, they passed the 500-page rule at Harvard. And I think that's a true story. Now that it's going out into the world, I'm sure I'll find out if it's not. But so it was a pivot back to the mission, because I think, and this is a leadership warning as well. I think when you are practitioners, and many of you will, and by the way, practitioner doesn't necessarily mean a nurse or a doctor, right? There are many kinds of field work that you can do. And that's true of research. I'm sure, in epidemiology, you have people who feel like they're in the field, right? Or consumed by, I know because we've done research in the middle of epidemics, right? And are trying to do that now with Ebola, to figure out, generate knowledge. But when you're under that kind of pressure, what are the first things to go out the door? Generating new knowledge, whether you call it research or not. I don't really care what you call it, as much as I do that we've got to learn from delivery. And training people formally. So the pivot was really back towards the original mission, and it's a very tough mission. If you're going to say we're going to leverage all of our service delivery with formal credentialing training programs for people who want to be our colleagues. You don't think there are people in Haiti and Rwanda and Malawi and Lesotho who want to do graduate work, who want to be credentialed, who want to be a nurse or a doctor or a professor? They do. And same for community health workers. So that was the pivot, really. And it's been very tough. That was 20 years ago, as you pointed out. And it's always tough to get us all to remember that the mission really comes out of the union of those three endeavors.
Yeah, that's fantastic. Thank you. I want just one additional question along this line, and it fast forward to 2010, and it's post-earthquake. And you and your colleagues and your partners decide to build a 250,000 square foot hospital in an environment that's been devastated. And that's another bold decision. And in doing my homework, I understood that you had to really stand that up, this decision, and you used the term, imagine the unimaginable. And I think that's another essence of leadership that I'd like you to share with the audience, what that experience was like, making this bold move at a time of such crisis.
Yeah, well, that's a great question. And I appreciate getting a chance to talk about it, especially when we're thinking about leadership, because this gives me a chance to say that sticking with equity and justice is never going to let you down in terms of leadership. It may be painful, it may be dangerous, it may be mocked, it may be disdained, it may be doubted, but it will eventually prove to be the right leadership challenge. You know, the great leaders, if we look back, they often are people who said, we really can't, we cannot allow this kind of disparity, injustice, inequality. And so to go looking back, whether at 2010 after the earthquake, or saying something like, if you are going between the Brigham and Women's Hospital here and a small hospital in rural Haiti, and you're, as I did as a intern, resident, fellow in infectious disease, and faculty member, you're going to see people with the same diseases, right? AIDS, for example. And imagine now looking back, people say, well, that was really great leadership when you push forward, treating AIDS in Haiti. But part of me wants to say, yeah, that's really amazing, Of course, these are not different species, poor and rich, black and white. So, it's the same thing with that hospital. I mean, the real question is, how could it have been regarded as overly ambitious, and go right through the list. That was the complementary part. To build a teaching hospital, a modern hospital, in a country, our oldest neighbor, in which all of the hospitals had just been destroyed. Right. That's the amazing thing to me, and it's the same around AIDS, or maybe we should have a plan to do something about driving down case fatality rates for Ebola, since again, it's a delivery problem, not a problem of a different pathophysiology for Liberians and us. And so to stand that up, as you said, it was very difficult. We had great partners, great implementers, great colleagues. We had, for the first time, support from people who actually did know how to build hospitals. We had built the hospitals we built with little in the way of professional help. So we had great partners, right? But you asked about the leadership, making the decision. It was much more painful than it should have been, because it should have been obvious that after all these hospitals were destroyed, and people died of trauma, by the way. Right. After the Boston Marathon bombings, there's a reason that no one who reached a hospital here died. And there's a reason why so many people died. That's right. In public health, you often hear people focus on the least common denominator. That's not a good way for public health to be. We should focus on equity and high aspirations and drag each other up. Now that's, again, a longer answer than you
That's wonderful.
wanted,
no, it's wonderful.
I appreciate it.
I would be remiss if I didn't ask you to comment a little bit about your strategies for tackling health inequalities in the United States, where resources are not as constrained as in some of the other places that you are known to work and have remarkable successes.
Well, the strategies, it's funny, there's in a way, it does lead me back to the generic strategy, which is also a leadership strategy, I believe, which is focused on equity, right? So, and there's an interesting, those of you in public health, I think those of us in public health, we can learn from errors made in the past, right? Pitting, for example, prevention against care. Right. So say you're interested in, I'm not going to start where you think I'm going to start. I'm not going to start with AIDS. But I'll just choose something else, like low birth weight babies. Right? Do you want to prevent low birth weight babies? Meaning not prevent them as being, but prevent them from being low birth weight. Then knock yourselves out, right? But some babies are going to need NICUs, right?
That's right.
So to pit better prenatal care against NICU care, this is just pure lunacy, right? Same thing, say, well, we should be focusing more on HIV prevention. Yeah, we should be focusing more on it. But that's not, you don't need to say, then on treating people with AIDS when it is the largest infectious killer of young adults in the world. It's kind of like saying, we don't need a teaching hospital, we don't need a modern hospital, we need, and then fill in the blank, when in fact, they don't have any modern hospitals because they've just been destroyed. So, going to the United States, there's a couple things. One I learned from the Haitians, and that is, I'm not a very good nationalist. They have a lot of reason to be nationalists.
Sure.
They've been under siege for a long time. I was born here, and I do love this place just as much as I love anywhere else. And there are some serious health disparity problems, and looking at them, they all have ways to prevent, to palliate, and I think, to improve or address even late in the game. And our strategy is sometimes to take lessons learned in Haiti or Rwanda and apply them here. For example, what is our weakest infrastructure problem in the United States as compared to Rwanda? And it's not hospitals. Ours are pretty good. It's actually community health workers. We don't have them.
Yeah.
And if we have them, they're not properly supported or trained. And so that's a powerful, they could be our allies in addressing health disparities. And we again, we need to look at the causes of the causes, right? But we also need to understand people do get sick. Meaning it'd be great if we could prevent all the pathologies that we do see in a hospital or a clinic here. But when people are sick, we also have to pay attention to their suffering. And even there, I think we're in trouble in this country, and we can, address those disparities of access to care much more aggressively and never pit them against prevention.
Right.
We should pit, military spending against prevention or something like that.
And I think earlier in your statement
or corporate welfare.
Or corporate welfare, but you also, we shouldn't pit the different levels of prevention against each other. So there's primary prevention
and secondary
and secondary and even tertiary. And that would be the reason for advocating for a comprehensive approach to health. Which,
in my view, by the way, just to contradict myself, I like military spending when they're helping us with Ebola. A comprehensive prevention. You can respect the social and economic rights of people living in poverty or marginalized by racism, gender disparities, et cetera, that we know make people more vulnerable. I mean, read Brian Stevenson's beautiful new book, Just Mercy, about the criminal justice system in the United States. And you can think about primary, secondary, tertiary prevention there as well. Beautiful book. And a board member of Partners in Health, if I can brag. But I think if we refuse to do that, and you refuse to do that, you're the future leaders of public health and scholarship, nationally, internationally. You say, we're skeptical about preventing. I'm looking at you, Amelia, because you take tuberculosis, right? Do we need better diagnostics? Yeah.
Yes.
We do.
Especially for pediatric populations.
We're missing, sometimes a half of them. Do we need better therapeutics? Yes, we do. We need better prevention, and there's primary prevention too. Better housing conditions, better job, social safety net that's going to protect workers who are and immigrants particularly, right? So that primary prevention can go all the way to, we also need, somebody has massive hemoptysis, coughing up blood. I need better thoracic surgery, but this comprehensive, seamless garment approach is very sound in public health and medicine.
Agree completely. I think this is time to invite the audience, and including those in the spillover room, can they communicate questions to us to engage Dr. Farmer in this discussion?
I miss you, spillover room.
Yes. Over here. Please introduce yourself.
Sure. My name is Fiona Lander. I'm in the MPH program. Thanks, Paul, for the wonderful presentation. I just wanted to ask, in this line of work, you see a lot of confronting things. How do you maintain the outrage without burning out?
Well, I think one of the things that we can do is say, well, that's outrageous, right? And you've already heard me say this in our class, but, I think it's outrageous that we have differential valuation of human life so that it would not be a national, international crisis to reduce case fatality rates for Liberians and Sierra Leoneans and Ghanaians with Ebola, for example, just as it was. So saying something's about outrage and then working with others to do something about it is one way to avoid burning out, right? The beauty of practice, you know, is, and I'm not talking about clinical practice necessarily, I'm just saying doing something, activism, being with others, thinking how are we gonna make this better? I think there's much less burnout than risk of burnout. I mean, I couldn't be a banker without burning out. I mean, I'd like to have some help from bankers, mind you. So I think this is a low risk, you know, it's tough work, there's no question, but the vitality of practice is a beautiful thing. And again, you don't have to be trained in a particular field. Like if I'm a, you know, a physical chemist, thank God I'm not, too difficult. It doesn't mean I can't be an activist at, you know, a church group or in a soup kitchen, you know, on and on it may go, right? And so I think that that's actually insurance against burnout, the kind of work we do. At least I feel that way. This is 30-something years, and I'm more excited about this work than I ever have been. So, thank you. Plus, you guys are my retirement plan.
Back there and then up front here.
Here is a question from our online audience, asked by the tutor user Rubes22. And his question is, how many hours does Paul Farmer sleep? What does he do for fun to balance his life, his family?
First one, none of your business. No, I'm
He might be a sleep medicine
kidding. Oh, in that case, you know, I'm lucky. I'm one of those people who can get by on not a lot of sleep, but you know, eventually it takes its toll. That's just physical, and then you need a break. And by the way, the more you're working with other people, the more you're spelled, you know, and somebody else is there to look out for you and take care of you. And you know, I think cultivating things that you like to do to step out of some of these grim situations, though invigorating, right? Is a very smart thing, you know. And I mean, and some hobbies are better than others. For example, I don't think it'll do much for my career or standing here if I say that part of mine includes bad action movies. But you know, everybody should have, you know, escapes like that, and it's great if it can be something. I actually, you know, I like to read fiction. I like to step out of my world and go into another one, and you know, and cultivating things that are beautiful. I'm looking at you as if you asked the question, but since the questioner isn't here, so I think it doesn't matter what my hobbies or habits are, but you know, cultivating those things with your family, if you're lucky, are part of, I think, staying engaged in the work. And you know, the other thing I would add is that families, this is a family affair, right? Global health equity, health disparities, in, you know, addressing our world's disparities. If you know, we need everybody involved. The kids, the cats, the dogs, the grandmas. So.
I think there's a question over here in the front, and then.
Hi, thank you again for being here. My name's Kristen Gilmer, and I'm a doctoral student in the DRPH program. And as infectious diseases are kind of the global spotlight in regard to the developing world, what do you see as the biggest challenge regarding the fact that non-communicable diseases like diabetes, hypertension, and heart disease are increasing? Do you think that the challenge is in the intersection and prevention?
Well, just to be something of a devil's advocate, I will say one of the biggest challenges is pitting pathologies one against the other, right, in activism. Yeah. So you really, I mean, it's kind of startling. I just saw a friend of mine who will go unmentioned, but he's an eminent public health figure associated with this school, recently returned from service to the United States of America and teaching in a certain program, which I won't mention, but you're in it. So, you know, he was describing to me the competition between people who were advocates to diminish hepatitis B and hepatitis C. Now, I would have laughed aghast, except that I've already seen all this, right?
Yeah.
So that's one of the biggest problems, is we're not fighting, you know, with people who are fighting NCDs, we're fighting NCDs. Or we're not fighting, you know, pitting tuberculosis against HIV. They already work well together. They play nice together to kill us, right? So that's a big problem, is this, we're all socialized for scarcity. We think we're competing for the same resources, you know, and that's a pathology that is embarrassing. That's why I'm putting at the top of the list, that we have to be very rigorous. The goal is better health and less suffering, and particularly for people who are living in poverty or marginalized by those. They're the people we're supposed to be serving in public health, right? The marginalized. So that's the goal, then we follow the burden of disease and gaps, right? And that will always lead us, you know, in the right direction. For example, if there was no Ebola in Liberia, we wouldn't be worrying about, you know, we'd worry about preventing it or surveillance, all the things. But, you know, but it is a major problem. And if there wasn't, you know, if there was no HIV in parts of Ethiopia served by PEPFAR, which is, you know, the President's Emergency Plan for AIDS Relief, it's perfectly reasonable that they say, well, what is the burden of disease here? And what are the gaps? And I think that, and fighting for more investments in healthcare delivery, of course, of good healthcare, and in training and in generating new knowledge, that should be our goal, and avoid the sort of, I was going to say cat fighting. It seems like a little bit too harsh, but I've seen it a lot, and as someone, you know, working in this field. And your generation should really stomp it out. And also, that's part of the leadership, to say, no, we're not pitting non-communicable against communicable diseases. We're saying we don't want people to die untimely of any of these pathologies, and we're going to study them to figure out what the burden of disease is and what's missing from other interventions, and then push for those.
And opportunities for synergy. So if you are working on a PEPFAR project, how can we improve infant mortality and maternal health as part of the spillover of enhancing capacity for healthcare delivery? I'm
glad you jogged my memory, because clearly we've learned a lot of things, right? PEPFAR and the Global Fund to Fight AIDS, Tuberculosis, and Malaria, you know, and I think this is, the leadership has been involved in this program already. But those are the first large funding efforts ever in human history for people living in poverty. Unless you look at colonial medicine, right, where you're saying, well, that's for the colony, and often that was for the white people in the colony, not for the, you know, natives of whatever part of France or Latin America we're talking about, or Asia for that matter. So this is entirely unprecedented, and we better have learned things, right? And one of them is that community health workers are key for chronic non-communicable disease, right? If someone has serious chronic illness, you know, for which there isn't a ready prevention, vaccine, or other forms of primary prevention, then we better, major mental illness is an example. Yes. Have we learned nothing about treating epilepsy, about major mental illness, about serious complications of coronary artery disease? And the answer is, yeah, we have learned a lot about it. We don't have a good strategy without community health workers. And we should be training, supporting, and working with them very closely. That's one synergy, back to Michelle's point.
It's a great question.
It is
Terrific
great.
Answer. Question over here.
Hi, my name is Luisa. I'm a medical student from Brazil. And I was wondering, I first heard about you as the man who would cure the world. My sister gave me the book before I got into med school. And I was wondering, I live in a very poor country, not as much as Haiti, but how do you keep it from being, how do you incorporate the local costumes and the local, I'm afraid it's something that I look at very skeptically sometimes. It's kind of like a colonization thing. And we see this in Brazil because most of the medical students are rich or are white, and our patients are poor and black. And I was wondering, how do you deal with that without being it, in your practice, without being something top-bottom or something that, well, that would cure the world without the other
Well,
part.
it's very interesting. I mean, it's a great question, first of all. And second of all is, again, I have a deep debt of gratitude to the Haitians because in my experience there, remember I was 23 when I started working there. I still work there. I just went from Liberia to Haiti, you know, which is not, there are no direct flights. But, you know, I've never had anyone Haitian ask me to look a different way. I mean, wear something else. You did say costumes. Do you mean customs?
Customs, I think you meant customs.
Okay, but it's still, you know, you remember what I did in my Ph.D. in anthropology, so those overlap, I guess, categories for us. And you know, if we were to say, well, if I was to have said as a med student or a resident, but you're a med student, you know, I want to integrate Haitian custom into our medical practice, I hope someone would have said to me, oh yeah, what custom are you talking about? Because it matters, right? Some of them are, I mean, they haven't been shown to be effective. Let's say I mentioned the 3 people who were personal friends of mine when I was in my 20s who died, one of childbirth, one of cerebral malaria, and the third of typhoid. And each one of them went through a hell before dying of basically a lack of access to modern medical care. Sometimes that involved local customs, but really what it was determined by the political economy of Haiti. Grotesque poverty, no healthcare infrastructure to speak of. And again, you could have said, well, you know, it could have been prevented. And by the time this happened, I had already had a few experiences of my own as a patient. For example, I was hit by a car when I was your age, a medical student in Cambridge. And if the ambulance attendants would have come over and said, should have looked both ways before you crossed, I would have been quite cross. And I hope my friends and family would have. They didn't say, well, we should have put prevention over care. They said, we're going to take you to, you know, the Mount Auburn Hospital, which was good. They did not ask me about my cultural background. They did not, you know, they were not interested in what I might bring. They took me to the operating room. And now that's an extreme example, but each of the 3 that I mentioned, there is not a different way to treat typhoid in Haiti compared to Massachusetts, or to treat cerebral malaria of someone who's a coma, or to prevent death in childbirth or its infectious sequelae. And so I think in my field, especially if you're studied anthropology and medicine, you're always at risk, I believe, of romanticizing cultural difference when what you're really seeing is structural violence. That's what you described. We're white, they're brown. You just said it, you know. That's inequality. That's not ancient Brazilian secrets, you know. And I think we got to be really hard-headed in public health about this. It's like structural violence, whatever you call it, inequality, health disparities, injustice, racism, all the things that it is. Let's all fight never to conflate that with cultural difference, because that is a very convenient thing for medical students and other helpers to do, is to say, oh, aren't these customs interesting and exotic, right? And that's going on with Ebola, too. Not that I feel passionately about it.
2 more questions? We have time for 2 more. A question back there and 1 more.
Hi, I'm Hannah. I'm in the Environmental Health Master's program here, and I've been very taken in your work with your use of the Haitian word for to be present and to be together. And I was wondering if you could talk about how you bring spirituality into your practice.
Well, yeah, could you be talking about accompaniment? Yeah. So it's true, I did get that. You know, if someone had said to me when I was 22 and leaving college, and, you know, what's accompaniment? I said, well, isn't that something that a pianist would do? Or, you know, I'd never heard the term used like that. And I'm so glad I didn't. It was early on in my experience in Haiti, you know, when the community health worker said, you know, what we do is we accompany others. And accompagnateur is the word that I kind of picked from them. And at the same time, I was reading it in, guess where? Liberation theology. You know, and I think that was very good for me because it was very, as I said, it was a painful experience. Not that it's not still painful. I mean, it's painful to see difficult and unjust things, right? But those were two different and complementary sources for me. The Haitian, the depth and the passion that I saw among the community health workers, and I'm not trying to romanticize, my colleagues from the 80s, and many of them still my colleagues, but I'm just saying there was a passion there. There's a lot going on in Haiti, admittedly, at that time in the 80s. And then on the other side, the more reflective spiritualism, spiritualities of the theologians I was reading. And I think they've informed our work for whether in a secular sense or for those who are seeking some kind of solace or direction and that you don't often get in public health.
One more question over here.
Hi, my name is Zara. I'm a first-year master's student in the Global Health Department. I was wondering, I guess what we sort of get hit with a lot here at school is how public health is sort of the intersection of all these different sectors, all these different players. And I was wondering, as I guess a public health leader, in sort of the backdrop of big pharma trying to negotiate access for third world sort of medicines, and how government intervention should or should not be a thing. How do you sort of negotiate access to that from a public health standpoint where, primarily the demand is, or the demand supply is market driven, it's sort of out of your control. So how do you sort of negotiate that from, 2-3 degrees of separation in terms of equity and sort of the bigger problem here?
It's a great question. I mean, I doubt I can answer it well or concisely, but I'll give it a try. I certainly feel passionately about that too. In the newspaper, the New York Times today, the Director General of the World Health Organization is criticizing what you call big pharma for delays in the Ebola vaccine. And I'm sure that, when I go through every line of it, I'll say, okay, I agree with that and I agree with that. But what you ask how I would do it, right? Or we would do it. And, what we would say is, okay, who can make the things we want, whether they be diagnostics or therapeutics or vaccines, preventives, right? And in the case of Ebola, since it's on my mind, that's clearly going to be big pharma. And also you mentioned the state or public intervention. And that's what NIH is too. Regulatory capacity is also a public function. It's not that investment in the product shouldn't be a public function. I'm not saying that. That's great. We need, those kind of investments because market failures clearly are going to occur always in healthcare and education. As Amartya Sen reminded us, yesterday, Adam Smith said that, right? One of the champions of the market said, yeah, but it won't work with healthcare and education. Did he not say that? So I agree that we cannot fail to have public and global interventions to promote public goods like a vaccine, and an Ebola vaccine is a good example. So I would say we're going to reach out to companies and say, hey, can we be part of this? Now, we would also like to be protected, right? Healthcare workers. We want to be protected from Ebola too. I'd sign up in a minute for an Ebola vaccine trial. I certainly sign up for a vaccine, but I'd sign up for the trial. So, and also what else can we offer? Well, if we have a community-based platform for delivering services, why can't that be a community-based platform for conducting research, right? Especially with help. So I think that's a really important thing. Not that the WHO isn't saying they would do it, but I'm saying they need implementers. And I'm not just talking about doctors and nurses, I'm talking about this team, this army of healthcare workers who would be the first beneficiaries probably, but also the effector arm to reach the millions of people who would need that or some other vaccine. And so I'm very interested in that kind of direct work. Did I answer the question? Market failure for sure. Healthcare, education, public good. You know, yes, we need to
Multi-sectorial approach
multi-sectorial.
to a complex health problem. So great response. We have some more time, and I understand we have a question from one of our remote viewers.
Hi, overflow room again.
Here is another question from our online audience so that they can also be part of the conversation. It's a question asked by Twitter user Meng Yao. And the question is, I want to ask, except for activism, what characteristics of leadership should we pick up as a student in the medical world?
I think humility would be up there. I mean, humility and listening are the first things to fall out of my mouth. And it's not because I'm naturally inclined to humility or listening. It's that leadership demands it, right? And there's time for, you know, in medicine like in other fields, and certainly in public health, there's time for, you know, I'm not listening so much right now, I'm talking. But I think that humility is we need more of it, and especially in activism and academics. You know, another part about leadership, as I said, is you never go wrong when you have a health and social justice, you know, agenda. It's not that that's the only agenda. I mean, you could say the agenda is, you know, developing some new tool. Those are great agendas. You know, new vaccine, leadership in a corporate sector or an academic department. There's so many ways to do it. I mean, I'm interested in scholarly work as well, but you know, global health equity is the right term for what we're doing. It's probably better than any, I mean, it's hard to find a better term, and that is a health and social justice endeavor. So physicians, he's a medical student or she's a medical student, and those are the three things I would put up there on the list.
I'm going to ask a question, we have a few more minutes and I'll come back to you. In 2009, you were one of the editors on a book, Global Health in the Time of Violence. And we haven't brought up the issue of violence. You mentioned structural violence earlier in this conversation. But what are the opportunities for medical students and students in schools of public health to play a leadership role in really bringing to the forefront the real important role violence is playing in the burden of disease and our capacity to actually mitigate problems such as getting vaccines to populations that need it because of structural violence.
You know, that is exactly the leap I would make that you just made at the end. There's so many different kinds of violence against women, violence of war, you know, chronic, low-grade violence like what's going on in, you know, Mexico, for example. And that's, you know, the drug trade, right? So in regardless of the kind of violence that you're talking about, and it's important to make distinctions about different kinds of acute event violence, right? But regardless of what they are, they're all pretty related to structural violence. And, you know, even though we don't have a prescription, you know, if we have a prescription, say, for, you know, active pulmonary tuberculosis, it's hard to know what the prescription is for violence. But one thing that if violence, this kind of violence, acute event violence, is related to the structural violence, what are we doing to link our interventions and violence reduction to fighting for equity again, to making sure people do have access to the kind of things that we would like to do, school, safety, you know, freedom from want, and that involves medical care. So I think there's a lot to be said for creating jobs and doing good health care, in, you know, and whether that be prevention or, I should say, and healthcare delivery. I think that's a violence prevention effort and a diplomatic tool as well. Indeed, the only kind of violence prevention I would know how to do is address these basic social and economic rights, the right to health care, the right to education, the right to housing. And why not get all crazy and say it would be great if people had jobs? You know, I've got one. I know they want one.
Thank you. We have a question back here.
Hi, my name is Martha Vega. I'm a med school graduate and research associate for the program of Global Surgery and Social Change. Based on your background on botanical... Hello? Okay. I'm just wondering, do you see any place in this whole world of public health where plant-based pharmaceuticals could be implemented? Do you see any future of that?
You know, I'm. You say based on my background in botanicals, I was thinking, wow.
From the very beginnings.
You know, I wish I knew more about that. It is true that you know, it's a hobby, but I would assume the answer to that question is yes. You know, I just don't know enough about it. I mean, of course, in infectious disease, I'm going back to, as I'm sure you can, to a number of the therapeutic advances that have already been made by plant-based therapeutics. That's been enormous, from aspirin to malaria care, to say nothing of modern malaria care. So I'm just assuming the answer is yes. You know, how best to do that, again, would require the kind of cooperation I was mentioning around vaccines, right? I don't know how to go from, you know, some insight from the Ho Chi Minh Trail to make, you know, coartem, but a pharmaceutical company would, and you know, finding out how to make that, you know, in the service of poor people is a tricky and important thing to do.
We have about 2 minutes left, I understand, and I wanted to just ask you to you know, share the top 3 or 4 things that this cohort of viewers might want to take away from this discussion around leadership in the face of challenging global public health issues.
Well, thank you, Michelle, and thank you for doing this. I mean, one of the first ones is that, you know, leadership is going to involve, again, creating a stage for other people to lead. And you immediately said capacity building. I think there's, you know, I look at my colleagues from Haiti, who are, I mean, the leader of the Partners in Health in Liberia is a former Haitian student of mine who's been involved in healthcare delivery for 10 years, and he's still young. But I mean, I work with people who believe that we should be creating, you know, ways for other people to lead. Another is you just don't go wrong when you're focused on health and social justice. Virchow or John Snow, you know, read the books, read the bios. I mean, they're actually quite the leaders of public health in the 19th century were much more focused on health equity and on social justice than the leaders of public health in the late 20th century, when all the rage was how much does it cost and how effectiveness is it, and let's have a formula. It'd be great to know the formula of cost and effectiveness, but it's not that easy. So humility, the third point, is one that I would elevate. Is we need to be more humble about, you know, getting ready to decide this is what a health policy should be based on what's affordable and what it costs, and more committed to going back to that social justice approach, saying this is what people need to be healthy and have agency and to live lives with less suffering.
Thank you so much. I really appreciate you sharing the time with us for this session and this discussion. And I want to also thank you, those of you here in the studio and those in the overflow room and even in more remote sites. I would also want to remind you that our next Voices in Leadership seminar discussion series will be happening on November 13th, where Dr. Mark Smith, who's a former president and CEO of Healthcare Foundation, will be here for discussing with us. So thank you very much. And again, please join me in thanking Dr. Farmer.
Thank you.